Well, welcome to our health equity seminar for November 6th. And today we're very happy to have Pon-Hsiu Yeh. Did I pronounce that right?
Yes.
Oh, great. Who's an instructor in emergency medicine at NYP Cornell and at NYP Lower Manhattan. And she completed her residency training at NYP Columbia in the emergency medicine residency program. Also has a health policy master's from the London School of Economics. Very impressive. Did you work with Lord Keynes when you were there?
No, I didn't work with.
Well, he was dead. It's all right.
Okay.
Also has spent time at Harvard's Initiative for Global Health and at Columbia University's Millennium Villages. She's hasn't had formal training in health services research up till now. Dr. Safford asked me to convey that and is looking for input and guidance and mentorship and opportunities. Her research interests include public health, health disparities, residency, wellness, and teaching. And she has an interesting project that she's undertaken, and she's going to talk to us about it today. And her topic is health disparities among Chinese Americans presenting to the emergency department.
Hello, everybody. So thank you for the introduction, Dr. Shapiro. And again, I am Dr. Yeh. You can call me Pon. That's usually what I go by. And I am, like Dr. Shapiro said, I'm pretty excited about this research. This is actually one of the first times I'm presenting it to people outside of the research group. So I'm definitely open to any feedback or definitely any questions or anything like that, because I've just been looking at this for some period of time, and definitely I'm sure there are other opinions and thoughts and everything like that. Throughout the presentation, if you have any questions or if anything seems to be confusing, you can definitely stop me and ask me to clarify. The title of my talk is Healthcare Disparities Among Chinese Americans Presenting to the Emergency Department. I'm gonna keep going and talk more about that. Let's see. So the background for this talk and the impetus for this talk, Asian Americans are the fastest growing ethnic population in the United States. However, they're often considered one ethnic group, and especially in terms of any sort of like census counting or polls or surveys and that kind of thing. In reality, as you all can probably suspect and know, health behaviors and health outcomes vary widely because Asia is a gigantic continent and there are so many different countries and religions and traditions and cultures. So it doesn't make sense that they are really considered one ethnic group, but that's what happens often in research. Specifically, I'm looking at Chinese American populations because I think that Chinese American populations may be different from just general Asian American populations. I'm specifically looking at Chinese American populations at the Lower Manhattan Hospital that's located in Lower Manhattan. You guys may be familiar or not with Lower Manhattan Hospital. It's located just off the Brooklyn Bridge in Lower Manhattan. And it's the only inpatient hospital south of Bellevue in Manhattan. So the catchment population is a lot of the Chinatown population because Chinatown is just a little bit north of there. So a large percentage of that Chinese population will come to Lower Manhattan. I myself, I am Chinese American, so that's part of my interest in this patient population. But another reason is prior to working at Lower Manhattan Hospital, I've actually never really worked with a large Chinese population clinically before. I've worked with, when I was at Columbia, I worked with a lot of that patient population was Dominican and Puerto Rican. At Cornell, there's a variety of different populations there, but it's not predominantly Chinese American. So just looking at the different populations and also speaking with my coworkers, we anecdotally felt like the Chinese patients seemed to be more ill when they were coming to the emergency department. They seemed to be older. They seemed to be more likely to be admitted. And I found this to be kind of interesting and curious, and kind of prompted this research because I wanted to know if the data, if the data kind of supported the clinical impressions that we were seeing. And so I started by doing just a broad kind of background research analysis, background research literature review. And I couldn't really find any similar studies that have been done in this population in the emergency department. So I think this research adds some value to the existing literature and research. So for this study, we had 3 different questions that we were looking at. And these questions, they compared Chinese American patients at the hospital to non-Chinese American patients. So the first question that we were interested in was, are the characteristics of Chinese American patients different from those of non-Chinese American patients? And I'll talk a little bit more about these specific characteristics in another slide, in the following slide. And then the second question we looked at was, do the outcomes in the emergency department differ between these 2 patient populations, Chinese and non-Chinese? And then the third question we were looking at was if there are differences in the outcomes, are these accounted for by the differences in the characteristics? This is the method slide. So like we talked about a little bit before, the setting is a Lower Manhattan hospital. It is an urban community hospital in Lower Manhattan. The ED volume has been going up every year, but over the last 5 years or so, it's about 40,000 a year. The study design is a retrospective observational study of the first visits of all adult patients presenting to the emergency department. The time period captured in the study is between April 2014 to April 2019. So we don't have any COVID data in this study. And then the data source is the electronic medical record. For our analysis, the main exposure, like we talked about a little bit before, is Chinese Americans versus non-Chinese Americans, so all other patients. The outcomes we're looking at for the analysis, these 3 outcomes were length of stay in the emergency department measured in hours, disposition, whether they're admitted to the hospital, and then the third outcome is whether they died in the emergency department. The patient characteristics we're interested in comparing, we grouped into 5 separate groups. So the first group we looked at was demographic characteristics. So this included age and sex. The second group we looked at were indicators of access to medical care. So for this characteristic, we looked at whether the patients stated they had a primary care physician or not, and also what type of health insurance the patient stated they had. And usually the health insurance fell into 3 different buckets: public, private, or self-pay. One of the other characteristics was the burden of chronic disease for these patients. So how much chronic disease these patients had on presentation to the emergency department. And we used the Charlson Index to measure the chronic disease burden. So if you're familiar with it, this is the Charlson Index is a way of categorizing comorbidities of patients based on ICD codes. It's been pretty extensively researched. And then we also looked at the acuity of illness on presentation to emergency department. And we used the Emergency Severity Index, or the ESI, to measure the acuity of illness. So the ESI is widely used emergency department kind of triage algorithm that provides clinically relevant data about the acuity of the patient. And it's based on the vital signs of the patient and also how the patient looks in terms of GCS or mental status when they appear at the emergency department. The ESI is assigned, it's one of 5 different numbers. It goes from 1 to 5, with 1 being the most ill patients. So an example of an ESI 1 patient would be someone who comes in cardiac arrest. And the example of an ESI 5 patient would be someone who comes in to the emergency department asking for a medication refill. So that's kind of a way to think about the ESI. And then the last characteristic we looked at comparing between Chinese Americans and non-Chinese Americans is the year of the visit, so the secular trend. We performed 3 different analyses for these outcomes. So for the length of stay, we performed a multivariable linear regression. For whether patients were admitted to the hospital, we performed a logistic regression. And for whether patients died in the emergency department, we performed a Poisson regression. So this is a chart of the sample characteristics that we talked about in the previous slide. So a couple of different interesting things. As you can see, this first column is the Chinese patients. So there are about 14,000 of these patients in this 5-year data set. And this is a non-Chinese patients, so about 107,000 patients in this data set. So in terms of years, the median years, Chinese patients were significantly older than non-Chinese patients coming to this emergency department, almost 30 years older. In terms of sex, Chinese Americans, 45% of them were male, so they were more female than non-Chinese Americans. And then in terms of primary care physician, more Chinese patients, a larger percentage of them had stated they had primary care physicians compared to non-Chinese patients. And then there were also differences in terms of insurance for Chinese patients compared to non-Chinese patients. So the large majority of Chinese patients, 74%, stated they had public insurance, while it seemed a little bit more even for non-Chinese patients on this side, 36% with public, 47% private, and 15% self-pay. The Charlson index that we looked at for chronic disease showed that Chinese patients also were more likely to have multiple chronic diseases. So we looked at a Charlson index greater than 2, so more than 2 chronic disease diagnoses. And for Chinese patients, it was about 6.2%, and for non-Chinese patients, 1.2%.
One quick question. Public insurance included Medicare, I assume?
Yes.
Okay, and you didn't you didn't have any separate categorization for Medicaid?
We did not look at that specifically in terms of separating it in this study.
Okay.
Thanks for your question. And then the ESI, the acute severity of illness in the emergency department, the median was about the same between Chinese and non-Chinese patients, with the interquartile range 3 and 3 for Chinese and 3 and 4 for non-Chinese. So some interesting differences in sample characteristics. I think we can also see some interesting differences in terms of the outcomes that we're looking at for these 2 patient populations. Chinese Americans were more likely to be, a larger percentage of them were admitted to the hospital, so almost 38% compared to non-Chinese patients. And then a larger percentage of the Chinese patients actually passed away in the emergency department, 4% compared to non-Chinese patients. And then the length of stay also was higher for Chinese patients compared to non-Chinese patients, 3.1 hours compared to 2.5 hours. So our third study question was whether these outcomes can be accounted for by the demographic differences. So that's what the next 3 slides will be looking at. It's going to be, this is our first regression analysis. So this is looking at the length of stay. And a really busy slide, but so let me try to talk you guys through it. So this is the crude length of stay we're looking at. And this, comparing Chinese patients to non-Chinese patients, there was a difference about 0.5 hours in length of stay. So Chinese patients were in the emergency department for about 30 minutes longer unadjusted for any of these other characteristics. And then when we adjust for the characteristics, the difference in time of length of stay decreases. So when adjusted for age and sex, the difference becomes 0.25 and 0.24, which is about a quarter of an hour, so about 15 minutes difference in time of length of stay in the emergency department. And then when we adjust for acuity with the ESI, that goes down to 0.1 of an hour, which is about 6 minutes. And then when we further adjust for access to care, chronic disease, and secular trends, the difference becomes almost clinically negligible, 0.06 hours, 0.07 hours. So I think based on this slide here, with the crude and adjusted models, we can say that the demographics, acuity, and access to care account for nearly all of the longer length of stay in the Chinese versus the non-Chinese patients. This is the logistic regression, looking at the differences in admission for Chinese versus non-Chinese patients. So we're looking at here at the incidence rate ratio or the relative risk. So in the crude unadjusted model, Chinese patients had excess risk 1.24 compared to non-Chinese patients for admission to the hospital from the emergency department. When we adjust for demographics, this incidence rate ratio decreases to 1.12, and then when adjusted for acuity, access to care, and chronic disease, decreases further here. So we can see that the demographics here, age accounted for about half of the excess risk of admission. But even when we have the fully adjusted model all the way down to here, 1.08, there's still 8% higher risk for Chinese patients for admission to the hospital. And then this third analysis is the Poisson regression analysis for mortality. And this we're looking at, in this analysis, we're looking at the odds ratio. And you can see just the crude unadjusted model, the Chinese versus non-Chinese patients in the emergency department, the odds ratio was 7.4 for mortality, which is quite high. But as you remember from the previous slides, Chinese patients were much more likely to be older and also to have more chronic disease. So when we adjust for age, that odds ratio decreases to 2, and for sex to 1.9. And then as we further adjust for acuity, access to care, and chronic disease, and the year, that odds ratio decreases to 1.52. But there still is this difference, even in our fully adjusted model, in terms of the odds for a Chinese patient dying in the emergency department. So this is a summary of all of the things that we looked at earlier in all the prior slides. In the demographic characteristics, we saw the sample characteristics. We saw that Chinese patients were nearly 30 years older than non-Chinese patients in this emergency department, and almost 75% of them had public insurance compared with about 36% of non-Chinese patients. We saw that Chinese patients had longer length of stay in the emergency department. They're more likely to be admitted, and they're more likely to die in the ED than non-Chinese patients. In the length of stay analysis, we saw that demographics, acuity, and access to care accounted for almost all of the longer length of stay, which was about that half hour in the crude unadjusted model. And then we saw that in the admission regression model, the age accounted for half of the excess risk of admission, with a residual risk of about 8% higher for Chinese patients that was not accounted for by acuity or access to care. And then the last mortality model that we saw that age played a major role in differences in mortality, but with also a modest role of acuity and access to care. But there were still about 50% higher odds of death in the fully adjusted model at the end. So the conclusions from all of this analysis that we did, it looks like Chinese patients had disparities in ED outcomes. And while demographic differences play a very large role, it seems like delays in seeking care, either through because of acuity or access or both, may play a modest role in these disparities and could potentially be targets for intervention. And then it also looks like that there may be other influences that might play a role, especially in higher mortality of these patients in the emergency department. As with any study, there are some limitations. In terms of how ethnicity is assigned, generally speaking, when a patient comes through the emergency department, registration will go to them and ask them, and it's a self-identifying ethnicity. Though sometimes, usually if the patient is altered or cannot answer questions, the registration clerk may assign the ethnicity for the patient. But that's quite rare. This data is all retrospective and observational. There are some potentially important variables that were not available that could affect mortality in the emergency department, such as DNR, DNI status. And this is just a one hospital single center study. So it's limiting in terms of how generalizable it is for other populations and other hospitals. So even though it looked like the data supports what me and my colleagues suspected in terms of Chinese patients being older and sicker in the emergency department, I think every research answers will lead to more questions. So this is some of the further questions we had and we're curious about for further research. So I think we're interested in gaining a deeper understanding of the factors that lead to the delays in seeking care, access barriers, and additional factors that lead to the higher mortality. And it would be interesting to talk to the Chinese population to see what they think is affecting all of these things. I'm interested in identifying institutional barriers to accessing care in terms of language barriers, cultural factors, immigration status. And I'm interested in discussing and collaborating with Chinatown physicians in the clinics in Chinatown. I'd like to see what their thoughts are about this research and why they think that there are these disparities and what they think would be good analysis, would be good interventions for decreasing these disparities. And I'm interested in looking at other ED quality indicators as well and seeing if these disparities also persist in other ED quality indicators. So I'd like to thank a couple of people, the Cornell Center for Health Equity, obviously, and the Cornell Emergency Department Research Group, who have been really instrumental in helping with analysis for this study, and also Lower Manhattan Hospital, providers, patients, and community. And I know I went through everything pretty quickly, but I'd like to open up for any questions or discussion, comments.
Wonder, could you go back to the slide that showed the unadjusted frequencies, one of your earlier slides?
This is for mortality.
No, unadjusted. Just basically the.
Oh, the outcomes.
No, the characteristics.
Oh, okay.
Yeah, looking at this, you have a population that's aged an average of 38 and a population aged average of 63. Mm-hmm. And in fact, no one in the non-Chinese group, well, I guess that's a standard deviation, but very few were old, right? I mean, most people were, at least from my perspective, young adults. Mm-hmm. In the Chinese population, they were older, for sure. And I know you did an adjustment, and I'm not a statistician, but I'm suspicious of adjusting to compare apples to oranges. And since you had a lot of people in the, like you had 8 or 9 times as many people in the non-Chinese group, couldn't you take a group of the non-Chinese matched more or less per age, or perhaps just look at the ones over the age of 65 and then maybe the ones 50 to 65 as cuts, and be able to see whether groups that are at least closer in age might look the same. I mean, talking about higher mortality, more time in the ER, and so on, when the age, when there's a 25-year difference in age, it's hard not to be suspicious that you didn't sufficiently adjust for any differences that remain. And the other comment related to what I asked earlier, which was about insurance. I mean, clearly an older population likely has Medicare. Medicare is a lot more like private insurance. And that might well explain the difference between the groups in that variable. But I don't know whether others agree with me. I mean, maybe it's perfectly satisfactory to adjust these groups that are radically different in age distribution, but maybe not.
I completely agree, Dr. Chabiro. That was going to be my first point as well, that you cannot adjust away that kind of an age difference. I have not seen any analysis that successfully has done that. So there's definitely, there could just be a lot of stuff left behind where you cannot fully account for the fact that there are two different age groups in this. You're comparing two age groups which just have very little in common. In fact, almost the lower end and the upper end are, it's really not, so you definitely need to do something else to find matched or equivalent groups. I definitely wanted to highlight that as well. And I had a question on the death. The death mortality variable is mortality in the ED or after they are hospitalized also?
It's in the emergency department.
So whether they come in and whether they die in the ED.
Yes.
So you're not considering whether if they get hospitalized, what happens to them after that. It's just that, so it's literally death within those hours that they are in the emergency room. I see. Okay.
Yes. For this study, I'm an emergency medicine provider, so I looked most largely in the emergency department, though I know that that is probably also a very interesting study for what happens after they get admitted and mortality as an inpatient.
But I think that because your outcome is also such a, it's just stands to reason that people who are much, much older are going to have a much higher chance of, having a, death at that point in time because they're coming. So yeah, I definitely think that the mortality one is the analysis on the time in the hospital, I think is interesting, or the time in the ED, that is definitely got some validity. But the mortality one, I would also be a little worried.
That makes sense. I think I can talk to the research group about different ways we can analyze these two groups since they're so disparate.
Hi,
Hey, Pon, it's Mark.
oh,
Go ahead.
you can go ahead, Mark.
Sure. I was going to ask, just make a quick comment and then ask a question. The comment is in relation to the two previous questions. And in a sense, I almost feel as though this disparity in age, totally valid points in that it's tough to compare those two groups, but I almost see it as more of like an outcome or an endpoint than a starting point, because the patients you're looking at are first presentation to the ED. So I think it's more evidence of a disparity in that Chinese patients are not ever coming to the ED before age 63 on average, and non-Chinese are so much younger. So I think it might just be a matter of how you look at that disparity and kind of how you frame it. But my question was, did you consider doing any sort of like propensity matching, or I don't know what the statistical term is, with other patients who are non-English speaking? In other words, maybe like harvest data from the Pacific translator, usage or something. And because I think at least in terms of length of stay in the ED, that might be explained away by literally just the time it takes to communicate with a translator. And I wonder if you'd see some sort of matching with other patients. We see a lot of Russians and some Spanish speakers down in Lower Manhattan. I wonder if you'd see kind of a matchup there. Just curious if you consider doing that.
So that is a really interesting study and something that's definitely feasible. When patients are registered, they actually, those are two separate variables. They specify what race they self-identify as, and they also specify their language. So that's something that can be looked at. We didn't look at other languages in this study.
Hi, could I ask a question and make a couple thoughts as well?
Yes.
Okay, thanks so much for the presentation. My name is Shashi Kapadi. I'm an infectious disease provider. I do my outpatient work down at Lower Manhattan and some patients too. I think similar to what Martin and Mangala and others were saying, I think that the sort of box of the non-Chinese population and kind of what that represents conceptually is probably really important here. Because I'm sort of thinking of it as the catchment area of Lower Manhattan, which means like a Chinese population that is like a New York Chinatown resident population that maybe has been there for a long time, and then a non-Chinese population that reflects everyone else who lives like down in that East Village, Lower East Side, Chinatown financial district area, which can be maybe not super representative of other emergency department populations, as you know. So I think it may be worth breaking that out more descriptively to help us think about it. Two variables that I think are important, at least from my time at Lower Manhattan or my experience, is substance use disorder, which is not really reflected in the Charleston particularly, and certainly not in the way that it's operationalized as a greater than or less than 2. So I think there is a large population of people with substance use disorder that maybe concentrates more in the non-Chinese box here. And then housing or unstable housing or homelessness or however you want to operationalize it kind of also probably falls along that line. So that may be two specific variables in addition to the ones that others have mentioned.
Okay, thank you so much. I mean, I have also noticed that in the patient population at Lower Manhattan. So those are definitely points that we'll look into, and they're not covered in Charleston.
I guess a follow-up is, do you have the ability to think about, would it be too weird or too like complicated to then think about ER populations outside, not at Lower Manhattan? Like, does this hold if your comparisons are kind of different groups in terms of their socioeconomic backgrounds and sort of other structural health backgrounds? Like, would this hold true at Weill Cornell, for example? That's a speculation question.
I would like to expand the study to other hospitals because I'm curious about the same question. This is just a kind of a first study, so that's definitely something I'm interested in.
Hey, thanks, Dr. Yeh. I too am an emergency physician. What I found interesting in your study is this ESI, that the ESI assigned to these patients were the same, but they had worse outcomes in the ED. And do you think there's something in there where, triage nurses, they're not looking at these patients as potentially sick? Because you would imagine if they were older, they had more comorbidities, they would get assigned a higher ESI.
I agree. I don't know the answer to that question, but I think that's something that would warrant further investigation as well. But you're right. The ESI is about the same for both populations.
I really think that with 107,000 versus 13,000, you can really trim the comparison population a lot to try to create comparable groups for some analyses, and it would be much easier to interpret. Because there's so many things about being older, like how long does it take for you to, get in and out of bed, and how much time does it take to go to the bathroom, and so on. I agree the time variable is an interesting one, but I think a lot of the other interpretations are very hard unless you can find a way to equalize the populations to some degree. And it seems like there are enough people there. In terms of why these are older Chinese, Going to the ER. I mean, I think that's interesting, and there could be some qualitative work about how people choose to use medical care. But in terms of the large numbers of other people that are younger, it might have to do with where people utilize care. You know, for example, there are a lot of people who work in Lower Manhattan that may need to get in for some issue or something happens and what have you. I mean, it's just complex. These aren't all residents of Lower Manhattan, I assume. Another way of thinking about that aspect of it is if you had zip codes, you know, you could even consider residential versus non-residential people in some of your analyses. And actually, the point being for some of the others, the non-Chinese might have used other ERs at other times, and you just wouldn't have that information if they're from other areas.
Hi, my name's Laura Kim. I'm a urogynecologist over here at NYP Queens. Great talk. A couple of questions I had, kind of piggybacking off of other people. In terms of the insurance, public being Medicaid versus Medicare, and actually the percent primary care physicians, did you do an analysis to see if you split the Chinese group into those who have primary care, if their outcomes were different than those who did not have a primary care physician? Because those who've had like Medicaid or Medicare would be more likely hooked into the system and therefore get some, you know, baseline preventative care versus potentially those who do not have that type of access.
Sure, thanks for your question. So we didn't split it in the sample characteristic in the outcome slide, but we did adjust for the primary care. We did use it as a characteristic and adjustment for the regression models later on.
Did you split it up by those with Medicaid versus those with Medicare in that group? Because Medicare patients are going to be older while the Medicaid patients might be younger.
Sure.
So then you can compare kind of like the non-Chinese younger patient group with the Chinese Medicaid group versus the Chinese Medicare group, which would probably be in that older age range. Was that part
we did not put Medicaid and Medicare. We put them together into public, and that's a very good point that we can look further into.
This seems like a really nice area to think about, and focusing specifically on the Chinese population as opposed to mixing in everyone who's Asian, I think will allow you to get at what might be culturally specific kinds of findings. And thinking about utilization and ER utilization is also a very good question. So, I mean, you've done some very nice preliminary analysis and are beginning to discern that there are some issues that require further exploration. Some of it is, I think a lot of the things you said that you're interested in inquiring about are good. I wouldn't necessarily, in going into the community, for example, focus too much on the results in their current form, because I think people might have the same kinds of questions we have. But I think this allows you to do more detailed and perhaps stratified analyses of the data that you have in hand in order to learn more about the population and about what the implications of the patterns of care are that you're seeing here. So it's a great start, you know. But as we always say, there's always more to do.
I agree.
Pon-Hsiu, I had a question on the, where did you get for the actual electronic medical record data? How did you how was the data extracted? Was it put into another database, and how did that process work?
So this This was all data that we extracted from all scripts, and when we ask for data from all scripts, there's a requisition process through Track, and I believe they give us files in the form of a spreadsheet, and then I had a research analyst. She used R, I believe, to do all of the analysis.
Okay, so you requested basically all scripts for everybody who's visited the ED from certain dates to certain dates, and they pull the entire.
And the specific variables we're interested in.
Interesting. Yeah. I see. Okay.
There's some additional questions or thoughts. Why don't we go to your last, or the slide where you had your ideas for future stuff, and see if we can
You mentioned earlier that the analysis didn't have COVID data. Are you thinking as a future area to look at if there's differences within the time period? We're still in COVID, but what that looks like?
I think it would be interesting. I believe that there are some ongoing studies already that look at COVID data based on different races, ethnicities. So I think that might be currently ongoing, but that's something that I agree is also interesting.
So sort of the first thing you list here, delays in seeking care, access barriers. You're hypothesizing that there are delays in seeking care, and you'd have to, and access barriers. There might well be, but you'd have to collect some data to determine if those exist. In terms of the higher mortality, again, you know, obviously looking at the differential age in a different way would allow you to think further about that, or thinking about whether you need to think further about that. The institutional barriers in accessing care, these are all good ones, I think. Talking with doctors about decreasing these kinds of disparities, obviously, they could be very helpful in thinking about what they perceive to be as barriers and disparities. You might want to think about whether you need to talk to, I mean, you talk about Chinatown doctors, there are the Chinese speaking Chinatown doctors, and then there are the use the translation service downtown doctors, and some of it depends on which doctors they go to. Other thoughts?
I think, you know, I agree with all of that. Of course, maybe this was very holistic in the sense that it was sort of an all comers, all diseases, all presentations approach, which I think is the right start. I wonder if you're interested in sort of additional quality indicators or additional exploration of what like the ER care processes are, and if they're different in some way. It might be useful to select a few almost like sentinel conditions that you think could exhibit that. I mean, stroke comes to mind for me, but there may be others that like you might be like, you know, this is where these are high ER mortality conditions in which we might see a difference between groups, and we can start digging down to like specific care processes. So that might be a follow-up thing.
Yeah, definitely. There are a number of different things, ER quality indicators, or I guess diagnoses that we look at: stroke, MI, sepsis, in some part maybe torsion, that we try to use as like process and quality indicators in the emergency department. So those are other things that we could definitely look at, and I'd be interested in between different ethnicities.
Some more comments? It's a really, really interesting set of questions. And I mean, I certainly think that, you know, having defined a particular population of interest, there's lots to be learned about them, about their utilization of care, about potential delays in getting care, about their perceptions of emergency departments. I mean, for example, there might be a delay in going to the emergency department because they would rather see a Chinese speaking physician and wouldn't feel that there was a guarantee that they would get to see one at the emergency department. I mean, I can remember patients of mine in Los Angeles who were Chinese speaking, that many of them also had a Chinese doctor. And, you know, and I would, they would come and see me periodically and I would make a recommendation, but they would almost never act upon it until they'd also spoken to the Chinese doctor about, you know, whether this was the right thing to do. So there might be some of that. So some of it could be cultural preferences. Some of it could be institutional barriers. Some of it could be language barriers. It's a complex subject. And you could spend a lot of time sorting all this out, but that might well be worthwhile.
Thank you so much.
So, well, I think we're probably just about out of questions, and we're going to be able to finish a little bit early so people can go back and check the election returns or else meditate.
I wanted to thank all of you guys for all of your inputs. Definitely very constructive, and a lot of different places to go with this research, and a lot of more work to do, but thanks for taking the time. And if you do have any other questions or anything else like that, I didn't put my email in here, but you can search for me on Cornell. Last name is YEH, or if you remember, it's POY 9001. Or you could just reach out to Grace and she would be able to give you the information.
Well, we look forward to talking with you again and hearing from you again. Thank you. And everybody have a nice weekend.
And Dr. Yeh, I don't know if you saw, Dr. Kim had a comment there for you in the chat.
I don't know if I can actually see it while I'm sharing the screen.
I will
says,
email it to you.
Would wonder how the NYP Queens ER data would compare since located in Flushing. Would wonder if downtown versus Flushing Chinatown population would be different.
I think that's definitely a really great question, and room for
also
further
says thank you for a great talk.
Thanks so much, everybody.
Okay, bye.